does that matter if it's daytime or nighttime?
I definitely notice that it hurts the most in the morning, like when I first wake up.
When you first wake up?
Yeah.
Okay, that's the worst.
Yes.
Okay. Well, so this patient had a history with plantar fasciitis for how many years?
It started about a year and a half ago.
Okay.
Yeah.
So properly diagnosed about a year and a half ago.
Yes.
Okay, so first thing I need to look at is, well, the common symptom for plantar fasciitis is a pain at the bottom of the foot, one or both sides. Tend to be on one side first. Rarely you see bilateral plantar fasciitis. How's the distance? It's all right, perfect. Yeah, just so you know it's live, so be a little bit more engaged on that.
Yeah.
Now, so I'm going to start just to look at the region first. You can see compared to the opposite side of the ankle, I can see there's a mild swollen because of the reflection of the light. You can see the difference. It's a very subtle sign, but you can see that this one is a slightly puffier compared to the one that's unaffected. So that can indicate that there's a mild inflammatory response or just fluid retention in general. Okay, so now I'm going to start from palpating. So I'm going to put direct pressure onto the calcaneus, which is the bottom of the heel. There's a bony structure here. Is it tender?
Not where you're touching so far.
So that's good, right? Now I'm gonna start to probe a little bit higher up where the insertion's at. How's that?
That's fine.
That's fine there.
Yeah.
Now I'm gonna go a little bit lower. That starts to hurt.
Yes.
So what kind of pain is it when I'm pressing?
It feels like sore, very uncomfortable.
Okay. Is this sharp?
No, it's not sharp. It's like, oh, yeah.
Yeah, so uncomfortable here. Yeah, so that's a very classic symptoms of plantar fasciitis, tender to touch, and it's located at the bottom of the heel. And when it's at worst, it will be even tender to just put light pressure on it. Now, so it's tender to touch. And what about movement?
That's fine.
Movement is fine, right?
Yeah.
And so that's fine. That's fine too, right? Okay, so well, generally speaking, plantar fasciitis it can be a primary cause of problem, meaning it can be causing from no reason just because of the overuse of it. But in clinic, you see plantar fasciitis is a secondary condition, meaning it's causing from other problems that cause the heel to be overused, either inability to connect to certain muscle in the calf muscle, or maybe poor mechanic, or there's a pelvis issue, low back issues that can also cause the plantar fascia to be overused. Now, so the treatment principle is this, because it's pain, and meaning it's I'm fairly confident that there's some inflammation going on here at the moment. And well, in order to reduce pain, that means we need to reduce inflammation. So how to reduce inflammation in this region? So there's one very effective therapy that we use. It's called radio shockwave therapy. And that is it's a physical mechanical wave that will be penetrated through the skin directly onto the plantar fascia. And what that does is to increase blood flow and reduce scar tissue from forming. Okay, we're going to do that first until the pain level has gone down. Then we will be working around the region to promote better supports and better stability, so that when the patient is weighted, the force and the point of contact will be shifted to more of a general broad region rather than one spot. So that's the whole treatment planning for it. Now I just set it at 2.3 bar with a shock wave, which is a moderate weight for the plantar fascia tissue. Okay, starting off from the bottom of it. Okay. Now tell me if it's too tender. Okay.
Ow! Oh my
Okay.
god.
Yeah.
Yep.
So now we know that we're hitting.
Tender.
Now we know we're hitting the core of the problem. So the patient acceptance is not very good. So that means we'll be divert them into the adjacent tissue to ease in. Okay.
Oh, I've got eating it. Oh my god.
Okay, that should be better now here.
Oh, that's better.
Yeah.
That's
So
better.
that's good. So we're gonna
Oh.
hand around here,
Oh my god.
so we can do a small circular movement.
Yeah, that's okay.
That's
Ow.
good.
Ow.
Okay, so that's round one. So we're gonna test it out between rounds. You doing okay so far?
His heart really hurts.
Yeah, so she's probably having an acute flare up at the moment. That's why it's
Yeah,
very
'cause
sensitive.
It didn't hurt that much last
Yeah.
time.
So how's that feel now? Should be decreased now.
Definitely.
Okay, but that's not enough because that's just starting to work now. Yeah, to get to it. All right, so that's
I'm gonna
that.
take so much revenge on you tonight.
Yeah.
I'm gonna come up to his resistance.
Good thing I'm
now.
going into one.
Okay. All right. So now the second round, we're going to really get to tackle the problem where the problem's at. Yeah. Well, again, I'm gonna start from somewhere adjacent, but still with a proper distance from the core of the problem, which is right there. So it's tender to touch still. Is that right? Still tender to touch or not?
That part's okay.
What about just right there?
That part's okay.
That's fine too.
Yep.
Is it gone? Where is it?
Yeah, none of that's hurting.
Oh, Jesus. Yeah,
Oh, there.
yeah.
Yep, there
so,
it is.
so now it's in a deeper fascia now, not the superficial. Okay, now go. And that's okay here?
Yep.
All right. Now we're gonna move into toward the nuclei of the pain. Now,
Oh,
Right
yeah.
there.
Okay,
Yeah.
okay. That's, oh. Okay. Ow, 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 ow.
yes. Okay, so second round, the patient acceptance has increased. Yeah, she's definitely not as jumpy, and also
Meditative state.
yeah, so she can meditate through it. And I was also checking her nails. It's like, wow, those are really cool
They're
colors.
fun, right?
Yeah, they're funky. And I remember yesterday I drove past. There's a Porsche 911 had the
This
exact
color?
same color.
Because that's on trend.
Yeah, that's not yours, is it?
Of course it is.
Yeah,
yes,
of course. How
Of
can
course
it
I drive
match?
a Porsche.
Same with the green Tesla too.
Absolutely.
Yeah.
I have several cars.
Multiple. Extra
Yes.
money.
Yeah, just
I
for
just like
just for
parking
different.
some of the-
One's my daily vehicle,
Yeah.
the other one's the weekend.
Absolutely.
Yeah, just to go with the different outfits, different
Yeah.
days,
I
right?
match my nails to my cars.
Yeah.
To my luxury cars.
Yeah.
Today I have no car.
Crazy. Oh,
Same as the bus. It's clear, same color. I know.
Yeah, so, okay. Now, so we've done the most painful part. So we've done total 1,000. Normally I go by 2,000 shots of shockwave if it's a chronic plantar fasciitis. But for today, it's only for pain reduction. So we're going to do around 1,000 shots. Okay. Now we're going to go check on the same region. How's that feel?
Much better.
Yeah, so I'm actually applying a lot more pressure to the calcaneus ridge, and the pain cannot be elicited, which is positive. But, okay, next step. Well, so the other problem of plantar fasciitis is the tissue compensation. So tissue compensation means the tissue around the inflamed part of the plantar fascia are being compensated due to this part has inability to be functional. So that being said, we also need to release the tension around the plantar fasciitis region. So I like to use a tool called Graston. So the Graston will help a couple of things. One will be blood flow, and the other benefits would be it helps to alleviate adhesions. So adhesion pathology you get to see more often for someone who has developed some chronic problem like plantar fasciitis in a chronic type. So they tend to develop adhesions or scar tissue around it, and that will make the condition worse over time. Now, so I'm gonna use this tool. Gonna get close to the insertion. That's fine?
Yep.
Okay. Now I'm gonna start to do some scraping. That's all right so far?
Yep.
Okay. So you can see it turn into mild redness. Then that's what we want. It's the blood, and we want the blood to stay there, so that can help cooperate with the healing. Okay, a little bit onto the arch here. Yeah, that's painful too, huh? Yeah, it's all good. It's all good. Yeah.
Oh. Ow, ow, ow. Ow, 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 ow.
Yeah.
Ow, ow, ow.
Okay. Okay, so that's the second part.
You have to edit this to make me look cool.
Hmm?
I need this edited so I look cool. Not like a big baby.
Wow, a bunch of babies.
Yeah. It really hurts.
Yeah, this part. Because it's very bony.
Yeah.
Yeah, I get that. Okay, so the next part is we're going to go a bit more distal from the plantar fascia. Okay, what other structures that's associated with the plantar fascia? Well, one is Achilles tendon, the thickest tendon in human body. And the Achilles tendon is an extension of gastrocnemius muscle. So if we release the muscles, and the tendon will be also released too. So that means we need to work on both regions, both muscle and the tendon itself. Okay, now we're gonna get the patient to switch to a prone position, meaning face down.
Yep.
Okay. All right, go feet up. Yeah, thank you. Okay, so for this part, let's get our calves out. Okay, let's move to this gastrocnemius muscle or calf. Calf muscle have two heads. So inside and outside, the inside of the head called a medial gastrocnemius, and lateral on the outside. And because the pain region is on the inside of the heel, so logically I will go for the medial side of the gastrocnemius muscle. So first step, what we're looking for in the muscle is to see and feel whether there's any abnormal tensions that can be felt. So that means any sort of rigidity, whether it feels rigid or ropey, and that can be a sign of it's being overcompensated. So right there, I can feel there's, which is the muscle belly here. There. Okay, now we're going to apply some appropriate amount of pressure to the muscle. At the same time, I'm gonna get the patient to dorsiflex, meaning point your toe toward up, point toes up.
I can't.
Try point your toe up. The opposite.
Oh my God! No,
yeah.
no.
Now down.
No.
Down. Yeah. Yeah. Move it down. The opposite. Yeah.
Oh, no,
And now go back. Now go back.
Oh, no.
Now go back. Yeah. You can do it. You can do it. Yes. That's good. All right. So. Yeah, so the patient acceptance is pretty low on this one. Yeah, but
She does not accept her fate.
but that's okay. We can find other ways to get the job done. So
Acceptance is the last stage.
so that's one of the ways to release the muscle, which is passive plus active engagement. But of course, because it's very painful, so it's gonna do the passive part. Meaning, gonna get a bigger surface. Gonna get the elbow to get in.
Oh my God!
Yeah.
No. Ow.
Yeah, it's all good. Yeah, keep breathing. Okay.
Okay, there we go.
So if it's a positive signs, the patient will feel an influx of warm sensation traveling down to her heel. I mean, whether she feel it or not. Some patients will say they feel warm down to their foot because of sometimes when the muscle are really tight, it can entrap the vasculatures, which is the arteries and the vein, deep into the calf muscles, so they can start to re-establish the blood flow down to the lower extremities. Now we're going to re-examine the muscle, and it's still tender to touch, but the good news is I couldn't feel any rigidity or ropey sensation. So I'll take that as a pass. I'll pass this one. So next one, which is a higher fibers in the same muscle belly. So sometimes you can have multiple regions that cause multiple contraction, that cause the shortness of the tendon, and that pose excessive amount of tension on the plantar fascia. Yeah, that's another tender spot.
Okay. Oh my God. Okay.
Okay, this part we're gonna get some lotion. Almost a marathon.
You're in your sprint.
Yeah,
Ow.
gonna get into it.
It hurts so badly, Cody.
Yeah, I know.
Oh my God.
It's a house of pain here, so.
Oh my God. Okay.
Yeah. All right, so I think the patient is very exhausted at this point.
Yes, she
And-
is.
Okay. Well, just still a little bit. Gonna get this part. Yeah. Okay. All right, so the point is not to really torture the patient, but the point is really to fatigue the muscle to a acceptable amount of tension, because we should keep some tension in the muscles. Otherwise, there won't be any tension to hold onto the joint, and the joint will be loose, and then the patient will get injured very easily too. We need to just keep the tension lower, and now I think we have accomplished most of the standard that we would like to see. So calf muscles are very compliant. When you feel it, it has a certain dexterity. The bounce rate is pretty good. And downstream, you're going to check on the same region onto the heel.
Like I feel it, but it's not nearly as bad.
Yeah, so it's still tender to touch.
Yes.
So of course, when she came in, the pain was at, how would you rate the pain when you came in?
Like an 8.
8 out of 10, right?
Yeah.
So now if I press on it really hard,
It's
it
like
probably
a 5.
that's decrease. Yeah, so 4 or 5 out of 10. And that's an improvement. That's what we're looking for. We're not looking to fully eliminate the pain, because your body have its own healing abilities. So we're gonna let the body to do its work to resolve its own. Okay, so that's a wrap.